Hi, this is Dr. Arsamendi from San Pau Hospital, Barcelona. I'm presenting two cases of the mitral valve repair with the H2H technique with the PASCAL system. We have selected these two cases because we think that it emphasizes the special features of the device that it makes probably unique in this setting. So the first case, it was a 60-year-old male with ischemic cardiomyopathy with moderate LV dysfunction and with a severe functional MR. He got admitted to emergency room several times. So for this reason, he was studied for mitral valve repair. This is his TOE. As you can see, he had a broad MR. You can see it in the intercommissural view. So for this reason, we thought that we might need more than one device. But on the other hand, if you check the LVOT, the quality of the leaflets is not really good. Despite it was described as a functional MR, there is some frayed leaflet in the posterior mainly. And for this reason, we were concerned that we might have some problems with a leaflet tearing. And for this reason, we thought that the PASCAL device was the device to choose because, as you know, the spacer reduces the stress of the leaflets. And at the same time, we are able to feel more regurgitant orifice area. So we get the both things at the same time. So this is the case. The thing is that we got a really good transeptal, and for this reason, we were really well aligned with the valve. And in the first attempt of grasping, we got a lot of amount of tissue, anterior and posterior leaflets. Normally, when we don't have to see it clear, we optimize the leaflet grasping at this moment. But since we saw a lot of tissue inside, we thought it was already a good grasping. We closed completely the device, and we had a really good result with a significant reduction of the mitral regurgitation with mild MR toward the lateral, and the LA pressure went down from 48 to 12. The patient did really well, and he was discharged 24 hours later, and he didn't get any other admission in the emergency room during the 6 months of follow-up. And this is the TOE at 6 months, and you can see that there was still a mild MR, almost a really stable result comparing what we got at the beginning. The second case is a 60-year-old female with degenerative MR that it was due to a P3 prolapse. She had also some issues with the bleeding, and she was refused for surgery because the geriatricians considered that she was too frail. So she was studied to transcatheter mitral valve repair. And as you can see, the case wasn't really promising because she had a large P3 prolapse. It measured like 13 millimeters. And we were concerned that it had a really weird angle, and to have an axiality with the leaflets, we thought that we might need to go down close to the chordae, and this was one of our main concerns. So for this reason, we thought that the PASCAL ACE device was probably the device to choose. For one side, because if we got trapped or entangled down the mitral valve apparatus, we will be able to elongate it, and it's a really safe maneuver to take it out. And on the other hand, compared to the PASCAL regular device, the PASCAL ACE allows us to grasp more tissue, 1 millimeter in each side, and we thought that for this large prolapse, it would be a really good device. So this is the case. We did several attempts of grasping, and indeed we got entangled a couple of times in the chordae, but it was really safe to take it out just with elongation. At the end, we accepted this position that it was like some sort of 11 to 5, and with that, we were able to get all the prolapse inside. Despite that, there was a moderate MR towards the lateral, and since the mitral mean gradient was of 2, we decided that it was worth it to put a second device to get it completely fixed. And this is what we did. The truth is that the second device was really easy to position because after all these tries that we did with the first one, the second one was just to put it side by side. And as you see, we got just a trace of mitral regurgitation, and the LA pressure, the V wave went down from 52 to 14. So the patient was discharged 48 hours later, and during the same procedure, she had the appendage crushed also. And this is what you can see at 6 months follow-up TOE. The result, it looks even better, and the residual MR is really traced, and the appendage is perfectly closed. She did really well, and she didn't got any other admission for heart failure. So these are the data of our first experience with the PASCAL device. As you can see, our average time of procedure is less than 1 hour. On those patients that has been treated with the regular PASCAL, we've been able to get a mild or trace MR in almost 83% of the cases. and none of the patients got a severe MR as a result. And if you go to the cases that we did with PASCAL Ace, that most of them there are prolapses, we got mal or trace MR, residual MR in almost 100% of the cases. So really promising results. And as you can see in the follow-up TOEs, they seem pretty stable. So in conclusion, the edge-to-edge mitral valve repair with the PASCAL platform offers benefits in several scenarios. We wanted to underline two specific ones in functional MR, and when you don't have a really good quality of leaflets, I think PASCAL is a really, really interesting device. And in the relative MR, it's really a good device to place close to the commissures, because the safety maneuver that we have with elongation is really, really useful. And especially PASCAL Ace is really useful in prolapses to get the full prolapsing tissue inside the device and get the perfect result. Thank you.